Next, we move on to the next talk, that is outlining the workup of a glaucoma suspect, especially after evaluation of the optic nerve head and diagnosing as a glaucoma suspect. Let's see what Dr. Kiran Gopalakrishnan has and how he has outlined the workup of a suspect. Dr. Kiran Gopalakrishnan is practicing as a glaucoma consultant since 2010 at Precise Specialty Eye Care, Trivandrum, and he is graduated from Government Medical College, Trivandrum, after which he has done his post-graduation and residency in the cornea and glaucoma at All India Institute of Medical Sciences at the RP Center. Over to you, Dr. Kiran.
Thanks, madam. And I'll be basically outlining the workup of a glaucoma suspect. So this is basically a bird's eye view and a concise view of what has been discussed so far. And just a reminder that when you say glaucoma suspect, it's not just the ONH suspects that we have been discussing all throughout. It also includes the category of IOP suspects or ocular hypertensives and angle suspects, which comes under the category of angle closure disease. But we have basically decided to concentrate on the ONH suspects as well. And the workup is essentially the same, except that in IOP suspects, the investigation of measuring the central corneal thickness becomes more important, and in angle suspects, obviously, gonioscopy is important. So let's start with disc imaging. Now, disc imaging is generally a grossly underutilized technology, but we have to understand that all the international societies gives a very strong recommendation to perform this test because the level of evidence to perform this test is very high. Why is disc imaging important? It is primarily important for two reasons. One is for reliable detection of disc hemorrhages. It's well documented that nearly 10 to 20% of optic disc hemorrhages are routinely missed on a standard 90D examination by very experienced glaucoma practitioners in landmark trials. So imagine the miss that we might actually have. The second is early identification of RNFL defects. Again, most of which has been discussed already. Look at this field. I mean, these are not well-defined defects here. There are some depressed points in the nasal areas, but not very well-defined defects. But the fundus image, you can clearly make out a supratemporal RNFL defect, which is further accentuated on the red-free image. Now, again, well documented that in landmark trials, if you don't take optic disc images, you are likely to miss out on a lot of cases. In the ocular hypertension treatment study, for example, 55% of patients who were being followed up, actually who had optic disc changes, had no concurrent visual field changes. So this has been well documented, and therefore this test is very important. We have talked about the ISNT rule before, but the ISNT rule was originally formulated on this paper. This was published way back in 1988 when the imaging technologies were more nascent. With more advanced technologies, we have actually found that the ISNT rule is basically valid only for less than 50% of patients. So that is basically because the nasal rim has a very wide field, it highly varies. So if you want to follow some rule and look for any break of the neuroretinal rim rule, it's probably better to stick to the IS rule, where the inferior is thicker than the superior, because this is basically present in more than 3/4 of the patients. Now, disc drawing is less desirable than optic disc imaging. Again, I'm not using the term myself. Less desirable is the term used by the American Academy of Preferred Practice Patterns. And the reason essentially is high inter-observer variability. So this is the father of a fellow ophthalmologist. So this is about 2019 disc drawing by a resident. Fair amount of details, normal size disc, no disc damage likelihood scale. I've marked it as 0.7:1. Now, when I am seeing this person for the first time now, and I'm looking at this disc, and I wonder if there is some increase in the concentric cupping from, say, 0.7 to, is this not 0.8? And that is the problem, because I don't have an objective disc image to compare myself to, say, way back in 2019. That is why this is less desirable. Second investigation, perimetry. Very strong recommendation to perform this test as the level of evidence is very high, all the international societies. The standard approach, the default choice should be Sita standard and not Sita faster and fast, which actually should be reserved for young and experienced. Experienced here does not mean age. Experience means perimetrically experienced. And Sita faster and Sita fast is easier for older patients is a misconception, because these tests usually employ much more subtle stimuli, and if you think that a person is looking very old, let us do a faster program, you will end up actually getting more unreliable results. In evaluation of glaucoma suspects, especially because we are looking for early changes here, you always focus more on the probability maps than the grayscale. When you have these subtle disc abnormalities, you can find that the probability map here shows a well-defined defect, whereas the grayscale looks almost normal. An important point for young ophthalmologists: do not discard field tests based on false negative errors, because they do not really affect patterns of field loss, unlike false positive errors. Let's look at this example. This is the 2023 image of a person whom I have been following as a glaucoma suspect since 2019. So I look at the rim, everything looks fine, the RNFL patterns are undisturbed. This is 2019 fields, normal in both eyes. 2020, 21, every year she has been doing fields normal. For the first time in 2023, when I'm performing this field test, I'm getting a defect on the right eye more and on the left eye a little less, marked as low test reliability because of a combination of fixation losses, false positive errors, and negative errors. Note here that the false positive errors is less than 10%. False positive errors, especially if it's greater than 15%, can really mess up patterns. Even when I repeated the field, I'm getting the same. If we look very closely, there is this defect is actually respecting the vertical midline. It is very subtle, especially on the left. It does respect the vertical midline. An MRI showed a large pituitary macroadenoma, and she underwent surgery a week back. When you have symmetrical field defects, it can be glaucoma, but whenever you see very symmetrical field defects based on other criteria, also think of possible masquerades. Well-defined inferior defects, not perfectly symmetrical, but well-defined defects. Now the problem is, we look at the disc picture, you will see that the superior rim is very thin or almost absent. Irrespective of how much investigation you do, say let's do an OCT, you will find that the superior rim is absent. But you have to be aware of these congenital conditions, because these can easily be mistaken for a normal tension glaucoma. You have to be aware of congenital conditions like topless disc or superior segment optic hypoplasia to make a diagnosis. Investigation will not really help you. Bilaterally symmetrical, almost central defects. And you have these bilateral temporal pallor. Here, it's advisable to perform a neuroimaging in such cases, certainly, but the visual acuity is the clincher here, because you don't expect glaucomas to have actually these low visual acuities with this kind of picture. Temporal pallor, neuroimaging is normal, but visual acuity is low. Again, madam has already described, this is a hereditary optic neuropathy, autosomal dominant type most likely. And of course, this presents a little different to the Leber's hereditary optic neuropathy, which basically presents more like an optic neuritis, except in the later stages when the vision loss will be much more than what is described here. Now, computer imaging. Now, a lot of discussion has been on OCTs. OCT is just one of the computer imaging, HRT, GDX, all comes under the category of imaging. And interestingly, unlike the other two tests, the strength of recommendation to perform this test on glaucoma and glaucoma suspects is very weak, and the level of evidence is low. Nevertheless, we have already seen that OCT can corroborate early defects. And see, an optic disc image shows a well-defined infratemporal defect, again more accentuated on the red free, but the fields repeated twice seems to show some degree of defect in the nasal areas, but it's not very well defined. If not for the optic disc image, we would probably discard this field. But here the OCT can kind of correlate, because corroborate the infratemporal dip, which you can see on the Tisnet graph. Myopic disc have been discussed. So myopes have generally two problems. One, there is a lot of peripapillary atrophy normally in myopes, and the disc also tends to be tilted. The peripapillary atrophy will depend on the degree of myopia. The problem, as has already been described, OCTs can be false positive. So this is not a very high myope, mild myope, -3 diopter around. You can see the tilted disc, and you can also see the peripapillary crescent. The fields are normal. And if you look at the Tisnet graph on the mean rim width analysis, you can actually see the supranasal dip. And of course, this is not a very high degree of myopia. If it was a high degree of myopia, this would probably be marked as red on the circle sectors, showing as yellow. But if you look at the B scan, you can actually appreciate the disc tilt in the B scan itself. And if you look at the RNFL again, you can actually see the thickness profiles have been shifted on either side compared to the normative database. Here, one thing that is relatively unaffected by the tilted disc itself is the macular cell, posterior pole GCL thickness, but it will be affected by myopia. So high degrees of myopia will affect the macular GCL analysis also, but it's generally unaffected by tilted disc. Most important, do not base your treatment decisions on OCT alone. A fairly advanced glaucomatous disc, the OCT circle sectors show normal, but the thickness profiles are elevated way above the normative database. And that is because we look at the B scan, you can see that there is an epiretinal membrane there. So the computer algorithm, instead of fixing the internal limiting membrane, will now fix the internal limiting membrane as the epiretinal membrane. So all the calculations of RNFL thickness will now be correspondingly higher, and this would basically come under the category of green disease, right? But the field effect is fairly obvious here. Now, this is a fellow cataract surgeon. So he has a family history of glaucoma. So I'm just showing you the left picture for clarity. The right eye picture is also the same. The optic disc looks fine. The imaging, the RNFL patterns, the rim all looks absolutely fine. Yeah, the fields are also fine. But then this is the problem. You look at the OCT, you find that there is an infratemporal dip on the Tisnet graph. And I repeated these scans twice. The circle scans at various levels, 4.1, 4.5, all are showing this infratemporal dip. And you look at the posterior pole GCL thickness analysis also shows an early inferior arcuate thinning, but the minimum rim width is normal. Now, this is exactly what I want to highlight. So you have a person who has normal fields, normal optic disc imaging, abnormal RNFL, which is usually the default test, and abnormal GCL, but there's a normal MRW. So you have tests which are not exactly corroborating with each other. This is why when you approach a glaucoma suspect, the workup should be one, balanced, where you ideally look for a good balance of neither overdiagnosis or underdiagnosis, and a multimodal approach. Multimodal approach means you perform all the tests, and within the tests you perform different protocols and try to corroborate everything. That is the multimodal approach that will help you in finally diagnosing a glaucoma suspect correctly. Thank you for your kind attention.
Thank you, Dr. Kiran. So I think we have listened to a lot of artifacts of all the investigative tools. And in the interest of the young ophthalmologist, if you could just highlight, if you have a person who is a glaucoma suspect, maybe in terms of the IOP being raised, or with the disc having some changes, or like you said, an angle having some problems, the basic things you would do in your first examination of the patient.
Yeah, see, suppose a patient is basically referred to you, and when somebody is diagnosed as a glaucoma suspect, is already your 90-day examination has been done, all the basic tests have been done. If first you go back to the history, and the two things that stands out in history, again, these are very well defined in the preferred practice pattern guidelines, would be first family history of glaucoma, and this is from history because I have limited time to cover all these things. History and family history of diabetes. These are two risk factors. In fact, in US, Medicare benefits allow any person with family history of glaucoma and a history of diabetes in them to actually undergo all the glaucoma screening tests, and always look for the triad of Raynaud's, sleep apnea, and migraine. These are especially useful when you are looking at normal tension glaucomas from the history. Then the investigation, as I said, starts with ideal and optic disc image, because this is very, very important for glaucoma suspects, not so much in well-defined glaucomas, because the whole idea of looking at a glaucoma suspect is to follow this patient up for a period of time and see if they actually develop into manifest glaucoma. Disc image is absolutely important, as I mentioned. Very strong recommendation from all international societies. Then perimetry. These two are absolutely critical tests. The central corneal thickness measurement becomes very important, especially in ocular hypertensives. And because of lack of time, now it is well documented in the ocular hypertensive treatment trial and the European glaucoma prevention trial. Both these are multicentric trials performed in two different geographical areas on different types of population. In spite of that, both these trials showed that CCT is a very important predictive factor for ocular hypertensives. And it's probably not that, if you look at other studies in glaucoma per se, CCT has not been found to be that important, unlike in ocular hypertensives. So, but still, as a part of investigation, we should do.
And a baseline gonioscopy.
Yeah, gonioscopy, obviously, because the diagnosis of angle suspect is basically on
Thank you, Kiran. I think